This is kind of the same, but anyway, it's a good topic to start with. So, yeah, it'll be fun. And next time, class 3, I think. Yeah.
Dr. Vicki, do you want to test out your screen? I can stop sharing.
Yeah, okay. Can see everything. We good? You can hear me still? Great. I just can't hear you, so you have to let me know when you want to start. According to it's in about 2 minutes. So.
Yes, in about 2 minutes.
Okay. And the audience here all around Southeast Asia?
Yeah, predominantly Vietnam, Thailand, and Singapore. So a lot from Southeast Asia.
Okay. Oh, Dr. An, I've got a call from you.
Yes, I tried to call you earlier.
Yeah. So what's happened since I've left? I'm missing everyone very much. Let me just get it. I hope you're still enjoying those coconut drinks, Dr. An. So do you want to, are we going to have a little spiel, or you want me to just jump straight in myself?
I can do a short introduction, Dr. Vicki. Just welcome the doctors and introduce you, and then pass it to you. It should take about a minute.
Okay, sounds good. Ooh. I've lost my screen.
Yeah, I'm just sharing mine, Dr. Vicki.
Okay.
Good morning and welcome doctors from all across Southeast Asia and our speaker Dr. Vicki all the way from Australia. Welcome to the Invisalign Step Up webinar series. My name is Isha and I'll be your host for today along with Dr. An from Vietnam. So, a quick introduction of the session today before we pass it on to our speaker. Please do note all the participants are on mute, and if you have any questions, please post them in the Q&A box on the screen and we will request the speaker to address them towards the end of the session. Please also note no photography, videography and recording of this session. Some general disclaimers as well. The statement, views and opinions expressed in this program and related post materials are those of the speakers. Align Technology Incorporated may not endorse such statements, views, or opinions. Attendees are responsible for legal and regulatory compliance of any marketing programs. And once again, please note, no video recording and photography is permitted throughout the presentation. So once again, welcome doctors to this very special program called the Invisalign Step Up program. And this is the professional education leg as part of this program. As part of the clinical education, we strive to help you gain confidence in treating a broad range of patients and malocclusions, which includes class 2, class 3, deep bites and extractions. In addition, you will also have experience virtual ClinCheck discussions with your clinical support team and also some practice development sessions with the marketing and the practice development managers. All of this to ensure an exceptional patient experience right from initial consultation till the end of the treatment. As part of the clinical education, we have these powerhouse speakers to run these 5 sessions for our doctors, Dr. Vicki Vlaskalic and Dr. Punki Huang. So welcome you all today to the very first session as part of the series, which is focusing on class 2 malocclusion. Without further delay, I would like to introduce our speaker, Dr. Vicki Vlaskalic. Dr. Vlaskalic attended the University of Melbourne, Australia, where she received both her Bachelor of Dental Science and Master of Dental Science in Orthodontics. She then received a research award from the Australian Association of Orthodontists Foundation for research and traveled to the US. Then she spent 2 years at the UCLA researching and teaching with Dr. Patrick, where maxillary protraction became her major research interest. She spent a further 6 years at the University of Pacific in San Francisco, where she obtained her California dental license and became an associate professor and director of the predoctoral orthodontic program. Her research interests included root resorption, mentored by Dr. Sheldon, and orthodontic treatment outcomes, mentored by Dr. Don Poulton. In 1997, Dr. Vlaskalic became the co-investigator with Dr. Robert Boyd in the feasibility of the Invisalign appliance, becoming one of the first orthodontists in the world to use the Invisalign system. Since returning to Melbourne, Dr. Vlaskalic works in orthodontic specialty practice, is also a clinical instructor at the University of Melbourne, and continues to act as a clinical consultant for Align Technology, lecturing and consulting worldwide. So, thank you very much, Dr. Vicki, for conducting this session, and thank you to our doctors. I would now like to pass the session to Dr. Vicki.
Thank you so much, Dr. Isha and Dr. Ahn, our wonderful hosts for this session today. And hello to all of my wonderful colleagues all over Southeast Asia. I wish I could be with you face to face. I think maybe recently I've seen some of you. For those who I have not, hopefully sometime soon. Congratulations on starting this Step Up program. Brings me back to a very exciting time when, before I started distalizing with aligners, before I started treating class 3, before we had the advancement feature. And, really it's such an eye-opening time when you're coming to that step up stage. Yes, we can treat class 1 and alignment fairly routinely, but now let's start going with treating patients with some more challenging malocclusions. It's just so satisfying, and to build that confidence to be able to offer patients with all types of malocclusions and feel confident that you can get the result with Invisalign that you could with fixed appliances. So without further ado, this is a large topic, but I know I'm with you for a few sessions, so I really hope that you will enjoy today enough, even if you're comfortable with this topic. We've got a lot of information to go through in the next few sessions until you finish with the wonderful Dr. Huang for finishing and some troubleshooting. So Dr. Isha did a great job introducing me. Just put my disclaimer there. I don't have any shares, never did, in Align Technology, but of course this talk is sponsored by Align Technology. And we've also seen the disclaimer slide there. Mainly that, this presentation is not necessarily company endorsed. Not all of the ideas come strictly from company protocols, but many are gleaned from my experience over 25 years of passion. It has been. It's a journey. That's a quarter of a century. So welcome. This is where I am sitting right now in my clinic in Melbourne. I was at the university yesterday, but today is a clinic day for me. And I am sitting next to my brand new acquisition here, which I've only had my 5D Plus for maybe about 3 weeks now. But I'm loving her. Ita is her name. And you can see this is one of the Align girls at the Itero consultant, Tanya Hill, who's helping me unpack. And it was actually very easy. I could have put her all together myself. But really, if we come full circle, going back to a scanner, those of you who really want to step up, I really, nothing's black and white, but if you don't have a scanner, you make the process so difficult. And really our goal is finishing complex cases as well as we can with fixed, and having the ability to just, look at a patient, reach across and scan, and immediately, have them entered into the IDS with our Invisalign photo app. That ability allows me to finish. That takes me 8 minutes to do the scan and the photos and to enter them and to order my finishing series. And that way I can finish with a digital appliance with the accuracy that really Invisalign deserves. So it's really full circle. For those of you who don't have a scanner, I really recommend, even some doctors who are buying new ones, try and get one of their old ones, perhaps if they're not trading it in somehow, because going through this process with PVS, it's very, very, very challenging and time consuming, and you're almost disadvantaging your outcome because the stress on the staff and the patient and yourself to take that perfect PVS, when you only need that very small tooth movement, then sometimes you think, well, I'm not going to bother, and then the outcomes are obviously not as ideal as what we want. So that's my recommendation, if and when you can get access to a scanner, for those of you who may not already. Our goal, any patient, is to have our clinical outcome within the significance of our treatment goals and the ClinCheck software program. There are 3 essential ingredients that go into this that we need to be able to manage: our patient and our education, the clinician, our knowledge, that's what we're doing here today, and of course the aligner and the mechanics. We need to understand that, and the company needs to, keep stepping up as they have been evolving over the last quarter of a century. Today we are addressing Class 2, and those of you who have heard my lectures know my favourite methodology for managing Class 2 malocclusions, be it an adult or a teen. It's going to be distalization with aligners. But I'm going to touch on, a little bit of a limited goal treatment, just one little mention about mandibular advancement feature, because we do have more options than simply elastics and aligners. And I'm mentioning the mandibular advancement feature. Those of you who may have tried the initial release many years ago, we know that it went in for a reboot and a remodel. The wings are now longer, they're reinforced. We have different staging protocols and different procedures with attachments, so the retention on the teeth. And I have to say that I'm not going to focus on mandibular advancement because it's not necessarily my area. My patient pool is not large enough to actually advise. Although, having said that, just probably an hour ago, my patient came in. This is a patient, Aidan Murray. His mother actually had orthognathic surgery for a retrognathic mandible, and his mother said, I want you to do everything you can so that he does not have to have surgery like I did. So we started Aidan on the new release of the mandibular advancement feature, and he came in today. He's on, I think, maybe 26. These are his progress photos that I took with the Invisalign app. Of course, this one's not cropped because this is actually the extra oral landscape. Those of you who are not using the Invisalign app, really consider it, because now he's automatically uploaded, to the IDS if I needed to do any finishing or refinement, but this is just a progress photo. So he's working really well. I'm very happy with the progress of the molars. Scissor bites corrected. We can do things simultaneously in terms of alignment, as well as concentrating on that mandibular advancement. His canines have certainly improved, and very much so his profile, which is wonderful. The overjet is really only about 5 millimeters, and that's being generous. It's probably about 4. So I'm really thrilled. So far, so good with the feature. Even though he did say he was playing with his wings a little bit, he found when he wakes up in the morning, he thinks that he's been chewing them at night, just the first night. So again, those of you who have heard me speak, usually I advise the changeover of the new aligner weekly at night so that it stays in there 7, 8, 9 hours without immediate distortion. I recommend that Aiden now puts his new aligner in with the wings straight after school. So his proprioceptors, and mentally he's got a few hours to get used to that new position and hopefully deprogram him a bit. You know, he's doing it subconsciously, so it's not something necessarily he can control. I'm trying to get his proprioceptors used to that new wing. So, you know, it might be a fact of different management, case management with these patients, but very excited about the progress. I used to use Hank's appliance for my functional appliances. I do believe in them, especially when we get those patients at the right time, and his mum said he's growing now, you know, he's just changed his shoe size. So it's the perfect time to encourage any extra millimeters we can get from that mandibular condyle and redirect that growth for him into that more anterior position. So for me, the jury's still out, although, you know, I'm always very excited about these new treatment options that we can offer our patients. So let's look at overall how we think about, or how I would consider class 2 when a new patient comes in. Of course, we listen to their chief concern. We're going to look at their extraoral profile, ourselves, lip competence, and, you know, retrognathic chin. Is there any change desired by the patient? And then we look a little bit deeper. If we detect a class 2 malocclusion or profile, we're going to then, you know, ask ourselves, is it skeletal or dental etiology? Because that's the true orthodontic diagnosis, right? Looking at the etiology, and an ideal treatment plan would be satisfying the cause. So if it was skeletal, then perhaps a more correct treatment plan would be surgery, orthodontic surgery. Even though we know not every patient will accept that treatment plan, it's nice to present it to them that they're aware that there is a skeletal discrepancy. Also, because when we do a camouflage, if we have a true skeletal class 2 base, you know, sometimes we're compromised. We can only do, the teeth can only compromise so much, so we can be limited. And if we detect that skeletal imbalance, I share that with the patient. Even if I know they're not going to have surgery, I will still recommend that they may want to talk to a surgeon, because once we camouflage, then we often, you know, the movements can be the opposite direction, as you know. I want to find out if it's comprehensive or limited correction, and that differs. Basically, all my young teens, young adults, I'm going to go for comprehensive correction. Not only do their teeth respond really nicely and easily, you know, we don't have that wear, we don't have the crowns and bridges, we don't have the restriction of changing their bite. We go for the ideal generally. In an adult, however, as we know, it may be different. They may not be prepared to have that 18, 20, 22 months of comprehensive class 2 correction. They tend to have a lot more restorative implants. We can't move bridges that are locked into that class 2 posterior bite. So I want to know what kind of movement I can achieve or to program in my ClinCheck software plan. So our options are to satisfy class 2 etiology, distalize the maxilla. Okay, and that's going to involve surgery. We can distalize the upper dentition, and our treatment plans to do that, the anterior dentition would be either aligners and elastics together, and or extract a premolar so that we can retract the anterior dentition and possibly need to mesialize then the posterior. On the lower arch, what are our options to correct a class 2? We would love to mesialize the lower anterior dentition. However, as we know, it is very limited potential to do that because very thin tissue there. So, you know, maybe a little bit of proclination to relieve some crowding, but we really need to be very aware of the roots of those lower anterior teeth. We can also consider advancing that mandible, either using surgery or, as we just discussed, the mandibular advancement feature. Aligners and elastics, I believe to a certain extent in that right age group, will act as a functional kind of an appliance. Again, if the patient is actively growing, we're all growing, but if they're actively growing through their teen adolescence, then there are lots of articles that show disocclude the occlusion. Class 2 elastics is really a type of functional appliance. So we probably get a functional effect in many of our young aligner and elastics cases as well. So there are options, and really it's just deciding which one of those or combination that we will decide on. Today we're going to focus on distalizing the upper dentition with aligners and elastics. We will come back at a subsequent session and discuss extraction. But for me, as I said, this is a functional effect as well. It's actually a tooth movement effect. We're saving the dentition from extraction, and a lot of benefits in distalizing as a treatment plan. This table comes from Dr. Somoto. We wrote an article together in the Journal of Clinical Orthodontics many years ago. And, he presented this, and I think it's great because it just reminds us that whether you extract or whether you distalize, the anterior, the lip prominence and the anterior dentition will be the same, assuming you distalize fully to a class 1 canine. So, it's a great treatment option, just as well as extracting first premolars, upper first premolars, for retracting and reducing that class 2, correcting that class 2 canine. So when we look at distalization with aligners and elastics, there are really two broad ClinCheck plans that we can prepare. One is called, as you know, the elastic jump, and you'll see these two options on your treatment planning form, on your prescription form. For me, the elastic jump is limited to, again, actively growing patients or really, really minor, 2, maybe 3 millimeters max. And 3 millimeters would be in an actively growing patient. In an adult, 1 or 2 millimeter. Why? Because this is they tend to be very short, not a long series of aligners. So it can look very wonderful because the jump corrects to class 1, but remember, in order to do that, we need remodeling and adjusting of the occlusion, and you'll get that quite effectively in a growing patient, not as easily in an adult. We might be creating a dual bite. So for me, it's limited, really very, similar to a fixed appliance patient. When we're checking their occlusion, they come in with their braces, bite down, they're a little bit class 2. What do we ask them to do? We ask them to run their class 2 elastics, and it's very similar. We're just going for that 1 or 2 millimeters to lock them in. So remember, the computer can make a beautiful bite. If we do it preparing surgery, we have a 5-6 millimeter jump, but just with elastics alone, make sure it's a realistic expectation from your patients, and of course it relies on compliance with elastics. Distalization is different. We're actually moving teeth through bone. It's not one jaw relative to the other or one arch relative to the other. We're moving teeth, and as you know, there are different staging patterns. This comes from basically the default staging, or what we call V pattern, or this would be almost a modified V pattern, because the anteriors are aligning simultaneously from stage 1. There is some alignment where possible of the anteriors as the molars are distalizing. And we're going to look at different staging patterns and the pros and cons of perhaps modifying a staging pattern. But, this is a very effective method for correcting class 2. And if you can get the patients early, my goodness, I had another patient today, apart from Aiden, a distalization patient. I should have taken progress photos, just beautiful. Canines fully class 1, as long as they wear their aligners and elastics, great. And of course, we have our virtual care app now, which I'm going to start using very soon, so that I will be able to monitor some of the teens that maybe need a little bit more monitoring and a little bit more contact between the 6 to 8 weeks when I would normally see my patients. So we know that for every, Newton tells us for every action, there's an equal and opposite reaction. So not everything works in the direction that we want. There are forces that work in the opposite direction that we need to control when we're talking about distalization. And typically, it's a really difficult movement with fixed appliances, right? We need a TADS, or we need pendulums, or we need carriers, and they have lateral side effects and other effects that have to be removed. But to move a whole arch distally is not going to happen unless it's surgery or perhaps, a TAD. So we need to think about, we're usually talking about a quadrant. It could be unilateral, it could be bilateral. How do we move? How do we control 7 little items and move them all in one direction at once? Well, again, unless it's surgery or TAD, we can't. So we use the concept of anchorage, right? What are our anchors? Can we use intra-arch anchorage? So something within the arch, some teeth in the arch already that will help to support and anchor that distalization movement of other teeth, just like the juggler does here as he's juggling the balls. All of them are not in the air at once. He is controlling, holding some still, and others are moving. And so we're going to use that concept of anchorage. Let's look a little bit further at this biomechanics. So when we move teeth with aligners, many of you will know aligners push. Right? Aligners push, fixed appliances pull. One big difference, and there are advantages to that difference. The other thing is that aligners, when we're increasing arch length, when we're opening space, maybe for an implant, or when we are distalizing those teeth, we have very few negative effects. The movement is controlled very well. So aligners love to push, and they love to increase arch length, whether it's proclination of incisors, whether it's distalization of molars, or whether it's both simultaneously. Aligners handle that very well. They are both highly expressive movements. So the proclination will be above 90% expression of the clean check. The distalization is around 85 to 87%. Again, very high for moving molars and posterior teeth in that distal direction. So highly expressed movements with very little negative effect. So we can move our molars back. We're pushing interdentally using other teeth in the arch, intra-arch anchorage, the anterior teeth, and backed up by elastics, so inter-arch anchorage, in order to support that distal movement. So we're going very well here. When does distalization, perhaps, when is the critical point in time? Aligners don't like decreasing arch length. And unless you have a very crowded class 2 case where actually the anteriors are not retracting so much, it's really distalizing to gain space. Maybe the canines are close to class 1, but most of the time we're correcting our canine relationship into a class 1 from a quarter or a half or a full unit. So at some point in time, we're going to retract the anteriors, and that's the time when we do get the negative effects. And if we're not controlling well, this is what we can see. It's very similar to the end of an extraction case. The severity of this tipping and loss of torque and posterior open bite will depend on how big that overjet is. How many stages are we cumulatively not just pushing back on the incisors and losing torque, but remember the equal and opposite. Every time we have a stage that's retracting, we have a stage that's pushing forward with that equal and opposite force on the molar segment. So we need to control this invisible force here that we don't see on our clean check, but it can act on that posterior dentition. So this is what we need to control. The way we can do that, we'll look at various ways. We can use attachments, either labial or palatal. We want to prevent occlusal interference. Occlusion, patients will wear aligners most of the day, but not all day. So patients will be eating and chewing and swallowing about 6 minutes a day. If they're bruxing with their aligners out, even more. And really only 1 or 2 chews is enough to push a tooth out of the activation, right? An activation of a liner is 0.25 max. And the give of a periodontal ligament or a mobile periodontal ligament that's been, orthodontic, of a tooth that's orthodontically moved is more than 0.25. A normal one is 0.25 ligament. So one bite knocking the tooth backwards, we can cumulatively lose a lot of our aligner activation. And that's going to result in, of course, some kind of non-fit or intrusion. So we want to eliminate very early on in our class 2 distalization plans any potential interference to distalization. So where would that come from? Occlusal interference to distalization. It comes from the lower second molar. Now, some patients are so young they don't have them erupted, which is great, or they're partially erupted. But in an adult, we want to get rid of that interference straight away, because otherwise the patient occludes and this molar will just, the whole aligner will just be pushed forward again. It can also come from the lower canine. If we're correcting a whole unit and we've got a very tight, we're really good at now creating that tight buccal segment. We want to create as tight occlusion as we can. If we don't have enough buccal overjet, we can't slide past the lower. Every time the patient bites down, that upper canine is pushed forward again, that whole aligner. And then finally, when the incisor retracts, if we haven't leveled our lower supereruptive incisors adequately, we're going to get that incisor interference, and that will result in the posterior open bite. So very early on, eliminating occlusal interference, and that involves intruding, as I said, 12-year-old molars. It involves sometimes I lingually incline slightly the lower canine so that I can maintain my distalization of the upper canine without having to round trip that one. Tends to be the arch with the most aligners, so I'd rather round trip the lower. It won't add treatment time. And efficient maximum velocity intrusion of my lower incisors, or at least early enough that I have enough overjet. I'm not going to bring my upper incisors too close. And then controlling that anterior distalization or retraction, that torque protection, which can come from a beautiful power ridge, which will be automatically triggered by the Smart Force engineering 3 degrees or more palatal root torque. We'll talk about power ridges. And also protection from that equal and opposite. Well, protection for this gives us another push surface, but attachments traditionally, we have now optimized attachments that will be triggered for distalization, but also the attachment will help to prevent this, this equal and opposite force. It just supports that molar a little bit more in the aligner. And of course, they're Smart Force attachments, so the active surface is generated in tune with the aligner touch on the tooth surface. And our precision cuts, hooks or cutouts for our class 2 mechanics, because remember, the distalization will happen without elastics, even the premolars, even the canines. But when you start then finally retracting, the anterior, when the anchorage, what you're moving against becomes more than what the anchorage segment is, you're going to then either tip or actually lose anchorage. So we do need to run elastics to prevent the loss of the distalization that we've achieved. And there's our class 2 hooks. So a little bit about the overview of mechanics of class 2 distalization. So let's go the big picture again. What do we need to control in this beautiful system that we have? What's in our control? In our control, we have ClinCheck and of course the patient. First of all, before we get to, patient control starts right at the beginning, right? Diagnosis, treatment plan, initial exam, explaining about what Invisalign is, using simulations. So education does start early. But once we get to the ClinCheck stage, then the programming on the software, we control these 4 elements: final position, IPR, attachments and features, and staging. So, you know, I like to keep it simple. Don't stress about things we can't control. Let's look at what we can control. And final position is something that we really need to control. It's important because it's used to actually manufacture the aligner, what we're programming. It's the combination of the company's defaults and our desire, our final goal. So make sure you put your final goal there. Otherwise, it's not represented. What you're getting is a default, which may or may not suit any individual patient. If we're not happy with that final occlusion on the ClinCheck, then the chances are we're not going to be happy in the clinic. You know, Emma, I've treated her years ago, but she's just the best example of a elastic jump. And really, this happens without me really knowing. So, you know, so many of our young patients have 1/4 of a millimetre or 1 to 2 millimetres of class 2 that need correction, and they're just correct so easily, sometimes even without, because we're not actually necessarily distalizing the whole arch a long way. It's just like, you know, as I said, fixed appliances. So sometimes without a lot of elastic use, they will correct, although having said that, definitely run elastics early. But, you know, the correction is so sometimes automatic. I don't like to say that because nothing's automatic, but we don't always notice. And I look back at photos and think, gee, that patient did start class 2 and now they're class 1. You just assume that they're almost always class 1 because the aligners are so effective at correcting class 2 malocclusion. So if we look at what an elastic jump is, so we can see about half a unit here. And, you know, this is definitely about my limits. And look at the number of aligners. If you have 14 aligners, you're not going to, you know, 3 months, that's all you're going to be able to run the elastics. So just think about the number of stages and the treatment time you have. Is that going to be equal to the jump that you're expecting from this patient? Yes, you can ask them to wear aligners for 2 weeks at a time instead of 1 to get more elastic wear. But remember, if they're really good elastic wears, those hooks can sometimes, you know, bend off if they're really wearing them full time for 2 weeks. So the final position, that's my message here with Emma. The final position is really crucial because the mechanics are really just the patient wearing their elastics. So that was one additional series of aligners. Really nice finish on the ClinCheck, you know, golden proportion, nice socked in buccal occlusion, and that's what we see. It's no miracle, it's what we see on the clinical results. And she wore some elastics, but very minor, just at night. 12 months of treatment, and you know, just that mild class 2 correction. Because the canines were high and they were coming down, you can see I did modify to button cutouts. Usually my go-to are hooks because I don't have to do anything. The hooks are there, they're easy. If there's a high canine, I then go to buttons because those mechanics of an elastic running to the button will work in my favour. I'm not relying just on the attachment for the extrusion and that very slight distalization. So message there is, in your jump cases, our job is final occlusion and alignment. In a limited goal case, a little bit different. Final occlusion is really important, but my goal for final occlusion and alignment is maintaining the posterior. These are patients that are satisfying, not as satisfying as comprehensive correction, but you know, they're sent in by their dentist. They just want some alignment so they can restore, they can get their veneer on there as quickly as possible. So as an orthodontist, I'm trying to get there as quickly as possible. They don't want any posterior change. And if there's no functional issue or restorative issue, then I'm not so concerned about doing that, even though it's not satisfying necessarily as an orthodontist. So my message here in final occlusion, limited goal cases I find can be more difficult. When we're treating comprehensively, we have an idea what class 1 occlusion looks like. Class 1 canine, class 1 molar, level arches, symmetric arches, midlines on, Andrew's 6 keys to occlusion. When we're dealing with a limited occlusion, a limited treatment, what does it look like posteriorly? For me, it looks like what the patient started with. So I right click and you can see on the ClinChecks and the superimposition, I'm not moving that locked in or that molar position, because what we don't want to do on a limited goal is give them a new bite. So it's really just anterior alignment, maintaining that, that initial bite. You can see, where's the grayed out? Yeah, so on the superimposition, those molars are not moving, because I do not want, you can introduce a little bit of movement, but I don't want to create a whole new bite. So that's my message with final occlusion on a limited goal treatment. You can see that graying out here. On the refinement, right click and you can lock a tooth from moving, from ourselves and also from the technicians if you haven't blocked it out initially on the prescription form. Really nice tool to use. And then the dentist can hurry up and place their restoration on that tooth. Would have been nice to do a little bit more and intrude, but patients happy, dentists happy. They wanted, that all they really wanted was uncrossed incisors to get that restoration on. So final position is, I think, where we need to pay most attention. And in a jump case and in a distalization case, I like to start from the lower arch. I like to give the technician an anterior limit, make that lower arch symmetric, take away any interference that I think. This is a young patient, so I can erupt to level some of those posterior teeth. In an adult, I wouldn't necessarily be doing that, but that will happen naturally in a young patient with growth. Intrude the super erupted segment. Look for the canines, avoid the canine interference as we're correcting. Derotate upper molars, which we do with our fixed appliances when we're correcting class 2. All of those class 2 detailing. With the incisor torque, what do you think we're going to have if we're retracting? If the patient's got a long overjet, we're going to have more torque. So those incisors, we will include a little bit more acute interincisal angle than what we normally would. Attachments and features, we'll go through that in a moment, as long as we've got our hooks there for our class 2 mechanics, and there's our class 2 final position and attachments and features. You can see I'm working on some aesthetic attachments. I'll have a word about those in a moment. Most of my cases have these, at least on the laterals, sometimes labial and palatal, but that nothing comes for free. You have to be careful at the end that they're not interfering as you finally close that overjet, but they are an aesthetic way of controlling and extruding or intruding or tip, or even helping torque if we don't have those power ridges. Superimposition, again, really important, just especially for that lower arch, to make sure that we're not creating any recession here and just proclining outside of that bone. Now, if you're taking cone beams, you'll be able to see the roots and the bone fenestration, which will be great. You can integrate that information into your ClinCheck. So that's a summary. If it's all right with a line, it's all right for me if you take a photo of this slide of the, what we look for when we create our final occlusion and alignment in class 2, which is really ideal as possible, but a few little nuances to compensate and to help us create that occlusion, that final occlusion. IPR, we do consider this when we work through every software plan, but in terms of class 2, there's nothing really particular or relevant You can use it perhaps if you're closing extra space. You can have some fake IPR of about 0.2 and not perform that clinically if there were spaces originally, or if you have some residual overjet and you don't want to distalize anymore, or if it's a limited case, yes, well then you can use IPR. That's pretty much all I want to say about that today, so that we can move on a little bit. Attachments and aligner features in relation to class 2. We all should understand as step-up doctors the differences between conventional and optimized attachments, right? Some are engineered by the difference between the position of initial and final position that we've created, and the conventional ones are just a generic shape that we can place on any particular surface of the tooth. It's really important, I think, to tell patients they're not there just to keep the aligners in tighter. They actually are engineered to help Invisalign express the movements that we need, the complex movements, to create a great smile and a great occlusion. If we're looking back at the mechanics of distalization, if you push with your finger on this crown, what's going to happen to that tooth? Thinking about pushing below the center of resistance, where would we place an attachment? The distobuccal cusp is going to intrude, so that's the cusp that we want to hold down in the aligner, and that's exactly where now the optimized attachments will be placed on that distobuccal cusp for exactly that reason, except the optimized attachments are smaller and smarter. They work in conjunction with the aligner force. This is brute old-fashioned technology, but it helps us think about the mechanics. Anteriorly, we know we need to preserve torque, so we can do that either with a power ridge. For me, it's going to be an attachment, just because I think it's more aesthetic, and it works well on the crown of a long incisor. And of course, keeping that acute interincisal axis, because we know we're going to lose torque as we retract, because we're pushing below the center of resistance. As I said earlier, very high expression of distalization. We have that anecdotally, and we have that in the literature. It's every movement expresses differently. Some will express greater than others, depending how many teeth we're moving, but distalization is a very highly expressed movement. So that's great. Back to these little horizontal beveled attachments you saw in the 3D, in the ClinCheck program, placing those, dragging, dropping, rotating the bevel. For me, the important thing is in the incisal third positioning, to make them even stronger, and to have this ledge about 90 degrees. We'll roll it out, make it high profile. You can see that pale pink padding about 90 degrees to the tooth surface. If it's a teen and you don't need to do this, if you don't have a picky adult, please, don't always think you need to put them on the palate. I do, it's almost a habit now, but they work great on the labial as well, and they're much easier to put on and take off on the labial. But if you need that aesthetic option, it is a good option. They do help control extrusion, torque, tip, and hold those incisors in while we're retracting. Just a word about power ridges. You'll hear different speakers love them, hate them, use them, not use them. You will form your own opinion. For me, on the upper incisors, I tend to prefer an attachment, either palatal or labial, here on the incisal third. I think a power ridge on the upper incisor, maybe I've been burned. It's sort of like the mandibular advancement appliance. When you use the very first release, sometimes it's been redone, and these are quite comfortable now and quite aesthetic. But my preference now is an attachment. What do power ridges do? They help with the force system, right? They help control the root as we're retracting, or to create palatal root torque. Do they solve the total problem for us? Do we get 100% of programmed palatal root torque if we use a power ridge? No, we don't. We'll never get 100%. No company ever will, because there's always a loss of energy. Do we get closer to the torque that's programmed if we use a power ridge? Yes, we do. but there's still quite a significant lag. So for me, it's a toss-up between aesthetics. Is there something, an attachment will not only help control the talk for me, but it will also hold these really annoying lateral incisors from intruding while I'm retracting. So I get, for me, more benefit from an attachment than just the talk from a parage. Also for me, when the incisors are already retroclined, there is not enough moment of force to control that root and push it all the way back. There are ways to manage that, and the way we start with a retroclined incisor, because what we don't want to do is straight away retract, whether it's an extraction case or a distalization. This is what's going to happen with even if it were a fixed appliances. So we prepare, right, the talk. And we can do that with, as I said, the software will automatically place that parage, and we will express more talk than if it wasn't there. That's clear, but it's not going to be as much as ClinCheck. So we finish with more acute incisor. It's much easier to drop the crown down at the end than to bring the root back once the patient's already been through a series of aligners. So we can use the parage, but we're still going to lose quite a bit of talk. For me, the easiest thing is what we do with fixed, because it's just what brackets do. When we place a wire in a bracket, especially a square wire ready for retraction, we immediately get proclination. Now in a bracket, that's bad because we're also losing anchorage posteriorly. But in aligners, we're not losing anchorage because they're pushing. They're actually probably helping the molars stay back. So this is a highly expressed movement to prepare my inclination, and simply ask the technician, maintain the inclination after proclination in retraction. I know I will still lose some of that talk, but because I have over-procline, I end up with an inclination that I like. So when you're looking at preparing retraction, look at your incisor inclination, because we don't want to end up with a posterior open bite from incisor interference. So very easy with the 3D mods, we have the option to torque our roots back or to procline. I'm just returning that, to procline the crown. This will also help with deep bite too, right? It's relative intrusion. So think about which option you're going to use, where your incisors are when you retract, and simply how far you're retracting. When we look at attachments and features, this is an interesting patient to look at attachments and features, because it brought me to look at the benefit of parages in the lower arch, and that's where I love my parages. So looking at the gingiva on the lower incisors, if you can see through that lip, it's actually pretty good. It's not a lot of washboard roots here. This patient was a dental assistant, about 2/3 unit class 2, not concerned about protrusion. She just wants a nice, not a class 2. She knows too much about occlusion now. So we prepared a distalization plan, and we didn't use the default. You can see it's a little bit of a modified, and this is when we're starting to stagger and distalize groups of teeth. We'll talk about staging for our very last topic. So the molars go back, and then the premolars and anteriors. Similar to what I do today, except I include the canine with those premolars. But the distalization wasn't the challenge here. She wore her elastics very, very well. The leveling of the arch, we're also taking 2 teeth down and then incisors. We'll talk about vertical mechanics when we talk about extraction, because that's 3D and really relevant to extraction space closure. It's more of a vertical problem than an AP problem, which is pretty amazing. So here she is in refinement. The distalization works really nicely. We have a little bit of, it's not refinement, that's the same one, a little bit more leveling to go. I'll show you in a second, just so I don't forget about the message of elastics. When do you run elastics? Mechanically, I think the answer is before the incisors retract, right? Because our molars come back with anchorage from 5 to 5, assuming all the teeth are there. Then the premolars, the middle section comes back. When we're retracting the anteriors, it's really crucial. For me, it's like putting money in the bank. Start early. Not on the first visit for me. I get them to use the Align as well. It's going to be on the second visit, which is 2 to 3 weeks later, quite early, and then after that every 6 to 8 weeks, but 2 to 3 weeks after delivery, go through instructions, make sure they're using them well, and start off with elastics at night. I start them slowly, they get confident. Maybe that's all I'll ever need to do. With the staging that I use, that's pretty much all I need to do after work and at night, or after school and at night. And I only use a very light force because I don't want that elastic pulling the aligner off the teeth. In this case, she wore her elastic so well, and I was really surprised to see, and doctors have asked during lectures, do you get, like with fixed appliances, dumping of the lower incisors and very prominent lower incisors? I had never seen it before, but certainly here, these roots were a bit superficial. So the distalization worked really nicely, alignment, a little bit more leveling to go, and one of my goals now in my finishing series is finish a little bit of leveling. It's not too deep, but still quite a bit deep, and protect the lower incisor roots. So I do have power ridges on my lower incisors. I love them in the lower. I think they protect that really thin tissue very, very well. And there you can see them at work. My intrusion mechanics, and there you can see we got the last bit of anterior leveling, and our nice class 1 segments, midlines on, and overjet reduction. So really happy patient, but very interesting about class 2 elastics. Perhaps you can use them a bit too much, but power ridges here, it's not that they don't work, they work so beautifully. For me, I love them in the lower. We're going to come back to bite rams. We'll talk about vertical, as I said, in the following sessions, but I do have a message about bite rams just before we finish, what to watch out for. So finally, what we can control is staging, and you can see that we have default staging, and for distalization, Align default, or the software default, will be what's called a V pattern, where the posterior teeth will move and then the anterior teeth will follow towards the end. We like to modify that for certain reasons, but really only when you have a good reason. Any default, whether it's taking off a Smart Force feature, a beautiful optimized small smart attachment, have a good reason. Why are you taking it off? Are you replacing it with something better, or are you removing the power of that? Because even if it's not getting you 100%, it's getting you closer to the mark. So same with staging. Have a very good reason. My reason for modifying staging is anchorage, increase anchorage, and
if you really want to impress your friends, 7-ball juggling is for you. It does take a lot of time to learn. This is what it looks like.
So remember the control. There's always something in the hand. Not everything's flying at once. That's surgery or attack. So the staging that I like to use to maximize my anchorage is molars together. I don't need aligners between the teeth. Then the middle section here, and I include the canine with the premolar. It's what I call the green zone. We can translate these teeth as long as the arch length is fixed or increasing. These come back really nicely. No trouble with root tipping. And then finally, this is what tends to be the problem, right? When we close the job, whether it's extraction or distalization. But in this scenario, we only have 4 teeth to control with our big anchorage segment. So much easier not to lose anchorage, less burden with elastics, and to control that torque. So I really like this staging. It's working really beautifully for me. I haven't really named it because Invisalign doesn't love names, right? Because doctors will ask the technicians. If I had to name it, it would be cake staging or caterpillar, because it looks like a cake on the staging, and the inspiration was from a caterpillar. But please don't name it, just ask for it bit by bit. Molars back, once they've finished, canines and premolars, once they've retracted, finally incisors, maintaining their inclination. It's as simple as that in the staging. So just an example, this young patient with quite a deep bite, very proclined incisors. So I don't have to prepare this inclination. They're already proclined. I could have started treating him here with Invisalign first. We waited until his premolars were a little bit erupted, and this is the clean check that we prepared, and you can see the distalization. Very important leveling, and again we'll talk about that vertical control on the lower because the staging pattern was modified with canine and incisor on the lower as well. But you can see optimized attachments are optimized distalization attachments, controlling the roots of the teeth. The only reason they're not on the canine because I want room for my button cut out, so I've just generated this diagonal one myself. It helps with distalization as well. So it's segmental staging. I can use the tooth table to see how far the teeth are retracting, and I want the root to be the same or a bit more. Now in this case he's very proclined, so I actually want to lose a little bit of torque. So they're programmed for exactly the same amount of retraction, 4.7. Gives you an idea of how much torque control and elastic wear you actually need. So Finn went to a refinement. He came from the country, and eventually I took off the buttons and gave him some nice hooks. And so we went a little bit early. Most of the distalization had been done. Just retracting those 4 incisors as a group, again maintaining that inclination. And here he is, August 21. Actually, I only saw him a few days ago. And then his finishing series, again, distalization really nice. In a teen now, we're erupting those 12-year-old molars, and you can see them erupting and just locking down any flared buccal segments. Buccal root torque will express quite nicely as long as we haven't overexpanded a lot and have a lot of hanging or intruded buccal cusp. So here we can see much nicer. He's still quite proclined, but actually did maintain that inclination quite nicely. We could have dropped a little bit more, but in his face, again, he's got good lip support and, very happy young gentleman now. And you can see the superposition, the really effective distalization on the upper arch, the super, and the lower is really just growth and a little bit of lower proclination. So inspiration for distalization through the caterpillar. What in nature can move a whole body? How is it doing it? Section, preparing anchorage, bringing the middle, and then finally the end. Our inspiration is from nature. Now how are we going with time? I think we're doing pretty well. Yeah. I started rushing, thinking we were going to run out of time, but I think we're going fairly well, which is good. So we'll have time for some questions as well. So let's take a look at this from a different view and what's actually happening and what you may want to ask for. So we spoke about the preparation of the incisor. So really important to look at the inclination of that upper incisor to start with. Is it starting retroclined, in which case proclining as you're distalizing works really well. Remember, aligners love to increase arch length and they love to push. This is very highly expressed movement. Nothing terrible can happen here, or no unexpected movements. At the same time, thinking about getting rid of the occlusal interference. And we saw that initially. Often the lower 12-year-old molar, if the patient has 12-year-old molars, it should be slightly supererupted from the 6-year-old molar. So, but if it's too far or if it's going to interfere with that distalization. Every case will be different. You can just slide on the ClinCheck to check intruding that. And it's not good enough just to ask for intrusion, but we want maximum velocity intrusion, right? Otherwise, we're going to get simultaneous staging. So it will intrude, but it's going to go very, very slowly all through. And when we're distalizing, this is in the upper max velocity in the first movement, we can't afford this to go very slowly. We also want this max velocity from the first staging. So intrude 12-year molar, max velocity. Preparing also the lower canine from interference, although we've got time before the upper canine starts retracting, but preparing our lower arch leveling. And I don't know if you paid attention to Finn, I might go back and play that ClinCheck, but if I have a very big curve of speed, I'll also use that. It's for a different reason. It's more on a greater force on a smaller surface area, intrude canines and then incisors and canines incisors. So if you've heard Dr. Simoto talk, he talks about, frog staging in extraction cases, alternating incisor and canine. So this is a vertical version, but it's for a different reason. It's not to get rid of a bowing effect. It's really to control force systems on surface area. And it came from something that we did 20 years or 25 years ago. It was before the marketing of Invisalign, where we were just experimenting with intrusion. And intrusion, even then we could achieve, because we were trialing, in the bench and pilots certain teeth, just 2 incisors at a time, and they intruded really well. So if we can do that, why are we lagging with our intrusion? Why is it becoming a bit of an issue? Deep bites, I think because we're trying to do too much with an aligner. We're trying to really level in adults, canine to canine, a long way, and that creates a lag and a non-fit and bubbles around the premolar. So this is just another way of approaching it, but we will talk about vertical dimension and intrusion mechanics, because its vertical dimension is almost the dimension that really can upset our extraction cases. So first aligner maximum velocity, get rid of the interference from the lower arch. We intrude lower second molars and then we level the anterior 3 to 3, canines first and then incisors. And at the same time, if the uppers are retroclined, in say class 2 division 2, for example, then we can prepare that inclination simply by crown tipping, not by root torque. Remember the message that we looked at a while back? It's we're getting smarter with what we're programming, and we can achieve the same final position with different kinds of movements. So again, instead of just torquing the root back, we can simply procline the crown and then retract. Because when we torque the root back, even though we will get some of that torque expressed, we might get 60%. If we're lucky, we'll get 70%, but we'll get 90% and more of proclination. So especially when it's a movement initially, we want our aligners to fit really well. Distalization plans are quite lengthy. That's a good question. How many aligners? If it's a full unit, I expect to see a full unit, maximum 70 aligners, but most class 2 cases can be done 40 or 50 aligners. And that's a high number of aligners, but it's way under 12 months. And it gives us plenty of time then to do that refinement finishing series, to perhaps finish leveling the lower arch, to torque in, the buccal segments. But the distalization should be done for me in ideally under 60 aligners is great, but it's going to depend on how severe the class 2 is. How far are you distalizing? In a full unit, the max is 5 millimeters, right? That's all we need, 5 to 6 millimeters, because that's the size of a dental unit. Often we'll go to a super class 1, so I'll overcorrect maybe by a millimeter or so. So, at four stages per month or per millimeter, we really shouldn't have more than those 60 stages. And of course, we don't like to make aligners unless we're going to use them. So the whole goal is not to just make lots of aligners, but to actually make them fit. And that's the compliance and the elastics and the wear of the aligners, whether it's virtual touch or whether it's, patient in the chair. You need to keep, incentivizing these patients, show them how much their class 2 is correcting once they're starting the elastics. So once our molars have gone back, we've prepared the incisor, then we're going to retract in a group here. This is what I call the green zone. So green zone is, for me, when I look at an extraction case or a transposition or a distalization, as long as I'm holding the arch length, there is actually, there is really, there probably is a tip, so that probably the crown will be moving more than the root. But when we look at our OPG, when we look at our occlusion, it's not enough to even measure clinically, let alone upset our outcome. So that's the green zone. Really taking these teeth forward or back works really well if we're holding the arch length. If we try and retract everything, mesialize the molars, retract the incisors, as we would see in a reciprocal extraction space closing, that's when we might run into a bit of an issue. But, and these teeth would just intrude and come out of control. But the green zone, they can go back all together very nicely. And then finally, again, this is where we would lose anchorage typically. This is where we would lose torque. We've prepared our torque and we've prepared our anchorage segment. Now we have 4 incisors against 12 teeth, canine, 6 teeth on one side or 5, depends if they've got third molars, second molars, but really lots and lots of root surface area to control those 4 incisors. So really beautiful anchorage segment. What does that mean? Less burden with elastics. Great. You can just keep wearing them at night. Very little, few cases, unless the patient wasn't wearing them well from the start, do we really need full-time elastics now? So our final position will be, final position will be a little bit overcorrected, so what we call super class 1, a little bit more correction on the canine, and really minimal overbite, overjet, because we're never going to get 100% on clean check, right? Where we'll get different degree of expression depending on how many teeth and what kind of movement. So that's what I call the, the caterpillar staging, and literally lying in bed thinking, how do we move one whole physical body? Is it even possible? Because, every now and then we can see amazing things on clean check and we pull ourselves back and say, is this actually mechanically possible? We need to start thinking again about our biomechanics. But yeah, it happens in nature. This whole body is moving in one direction, but it's moving in sections and preparing its anchorage. So we can get our inspiration from that beautiful caterpillar. Now, a lot of doctors, particularly in Southeast Asia, will be faced with patients who are more protrusive than perhaps what we typically see, perhaps in Australia or the US or other countries, other populations. Even though these days we see everything everywhere, right? The world is getting smaller. But doctors will be asking, do you use TADs? Do you need TADs? For me, there is no need here. A TAD, what's it going to do? I can distalize as far as I want with aligners and elastics. I can keep going. It's going to be the anatomy that blocks me, right? The tuberosity, or if it's a class 3, it will be the ramus. And we have great anchorage, especially when we stage this way. So what is a TAD going to really give me? The only case, I think, where, it's probably going to be logical, because remember the distalization here, even though I'm preparing this staging with intra-arch anchorage in mind, so using the other teeth in the arch to push against. The other source of anchorage are the elastics, right? The inter-arch elastics, so running from the maxilla to the mandible, and that's also helping hold back that whole aligner while everything's going on internally. So do we need TADs? If I couldn't use run elastics from one arch to the other, and if I wanted both arch distalized, then I think putting a TAD, using it like this with an aligner, actually can make sense. The staging for me would be the same. The molars would go back, then the TAD would go in, canines and premolars, and then the anterior. But really, I haven't had that indication because I can correct a full unit without having to do this. It would be really a class 1, really bimax, where you're just not going to extract. I don't know. I think extraction these days is probably easier in a class 1 bimax. You can get that space for the anterior traction sooner, especially seeing as our extraction mechanics, we're much more confident with those these days with aligners. So I know someone's out there in the audience probably thinking about this. If we really have to, if we're faced with this, how would we do it? For me, it would be, maintaining that buccal occlusion, distalizing the molars together, then placing the TAD, distalizing the green zone, the canine and premolar, and then finally the incisors. And the TADs would be running from the hook from the canines to the TAD. And that way it's backing up the intra-arch anchorage from the aligner. But have I got a lot of experience in this? I have to say no. Mechanically, this makes sense to me, but probably I would extract in this kind of a patient anyway. But for those of you who love TADs, and really, really want to back up your anchorage, that's not a difficult setup to do. Just make sure you don't forget your hook on your aligner. So, troubleshooting, putting out the fire. We've looked at probably the most common method. I think that, around the world, distalization with aligners is really becoming a very routine part of class 2 correction. So what are some of the pitfalls? What are some of the dangers? Looking at everything systematically, getting our final position really as ideal as possible, with those small considerations about fully derotating the upper molars, looking at your canine inclination, make sure, that's working for you in terms of getting class 1 canine. If anyone's asleep now, you can wake up with my nails, right? They're very, very bright. They look very bright on the screen. And then the staging has also helped, create this, it's taken the burden off. Oh, gee, is everything going to, is the patient wearing the elastics? And also that loss of torque and that incisor interference at the end. But what else can go wrong, or what can possibly go wrong? Let's take a look. Nothing always goes perfectly smoothly. The message is stop. If something's not working the way we like it, we stop and we think about it. Are we off track? So, for me, it's the 6 C's. The patient comes into the clinic and we greet them before they sit in the chair and we want to talk to them. Are they wearing their aligner? Is it on their teeth? Because it shouldn't be in the pocket or in the school bag or in the car or in the handbag. That will immediately raise alarm bells. It should be in the mouth. If they're speaking very clearly and telling me what they did on holidays and I can't really hear the aligners in their mouth, great, a tick, because compliance we know is already going to be fairly high. The speech is normal and we can't see the aligner clearly on the teeth. That means there are no big gaps there. The patient's probably quite compliant. So that's great. All of that we can see before we even look in the patient's mouth. Then we lie the patient down and we have a look with the mirror around the aligner. You know, how is that contacting around the actual tooth? And we're looking for bubbles or any air spaces, attachments in the divots. And that will give us a clue where to target in if there are any of those areas once the aligner's out. So then we can ask the patient, you know, what number aligner is this? And they should know. If they don't know, then it's kind of a little bit scary, because my patients should be very involved. I don't want them to make a mistake. I don't want them to skip any aligners or to go back unnecessarily or forward. And believe me, and it may have happened to some of you, it happens, and it's not just a new patient. It's often someone who's been using aligners, and it might be their refinement series and they're just getting a bit lazy. So I always like the patient to know what number they're changing into. And I ask them what their change day is. When did this aligner go in? What's your change day? And we talk about the time of day, preferably before bedtime, that aligner goes in. Maybe for the mandibular functional appliance, for me, it's going to be after school or after work. Most of these patients are going to school because they're young, the functional appliance patients. So I want the patient to tell me what number aligner it is. Then I know how old it is when they put it in. Is it a 1 day old aligner, or is it a 5 day old aligner? Ask them to take it out, or these days I flick it out so we don't have to put sanitizer back on their hands. And I have a look at the condition of the aligner. So is it bright yellow? Then, you know, it's coffee, turmeric, those kinds of things. Is it got dry plaque and saliva, in which case we'll talk about the lemon juice or vinegar that will help, you know, to clean that aligner, the brushing of the teeth. And is there any, you know, the comfort layer, is it peeling or not? Which will give us an idea, are they bruxing or chewing, which can actually have an effect on the tracking of the movement. So then we'll have a look at the attachments, use the treatment form. If you've got it on screen or in hard copy, we put ours in a little plastic, in a plastic folder. I've probably got one sitting here. Most of you are probably paperless now, but, you know, I put mine in the plastic folder, and this comes out and sits with underneath my tray. Where am I? It's not showing. There we go. Underneath my tray. It's really hard to get the depth right in the camera, and that way I can see where the attachments are, if there is their IPR. So either, you know, do it on the computer or the hard copy, but the plastic cover is a really good idea, and you can just wipe it down with that tray. Again, most of you are probably paperless. And then looking at the attachments, checking they're all there. If one's not, do we need it? Maybe I didn't put it on in the first place because there was a crown there. Maybe there's an amalgam or a heavily filled tooth. I don't want to bond to a heavily filled tooth, so I'm going to leave it off. And if it's not there and it was, do I actually need it anymore? Has that tooth moved? And then we will close together the classification. Do we need to run any elastics? How are we going with our classification? Are we correcting class 2 or class 3? And the contacts. So is there any IPR, any contacts that we need to pay attention to? So that's really my in-house, and it's the 6 C's, right? You know, the contacts, classification, compliance, condition of the aligner. And that way I can remember really, really nicely. So what we're going to identify if something's off track, is there a tooth that's not fitting? And then we ask ourselves, okay, why? Has it intruded a little bit? Has an attachment come off? Does it matter? Is that intrusion actually upsetting other movements that may be larger movements? If we're distalizing, are we going to stop everything? Maybe if a lateral incisor is intruding a little bit. That's going to depend on, you know, is it an aesthetic problem? Is it something that's bothering the patient? I like to have very aesthetic aligners, because if they're not aesthetic, what do you think that is going to do? Does the patient want to wear an aligner that fits perfectly, or one that has a big gap on one of the teeth. They're going to want to wear an aligner and be proud to wear an aligner that fits well because it's hard to see. So then I might use a simple extrusion technique to recapture that tooth. If I'm coming close to the end of the series and everything else is still tracking, then I'm going to leave it, and in my refinement series, I'm going to use a different strategy. Maybe replace an attachment there, maybe have a different staging, depending on what the cause for the off track was. And that's really important. You know, it's a tipping movement, intrusion. We'll talk about uprighting teeth next time. Maybe not next time, probably the time after, when we talk about extractions. When we're focusing, so that's a general off track. When we're focusing, and I think Dr. Huang is going to talk to you about finishing, which is great. When we talk about class 2 correction, one of the main things that I really don't want is incomplete distalization, because then we have to make a decision. You know, by that time, the patient's been through perhaps 12 months of treatment. And we need to make a decision. Are we going to repeat that all over again? It can take maybe 9, 10, 11, 12 months, depending how far we're distalizing, to finish that distalization and more elastics. Or are we going to settle for that partial correction, which is not something that was in our treatment goal. So this is something that we really fight hard to prevent, by incomplete distalization. And that might be right from the beginning, educating the patient what is needed when we're not extracting, but we're distalizing with aligners and elastics. Are you prepared to wear your aligner and your elastics? So education from the beginning. The next thing we can do is to prepare a great ClinCheck plan. We can overcorrect our distalization slightly, not by masses. And in fact, I've had some cases where I can see that overcorrection. They've actually gone into almost a class 3. So, you know, I'm talking about 1.5 millimeters max for me will be an overcorrection, because this is a highly expressed movement. We're not losing a lot. The studies show only about 10%. So we're going to get around, 87, 90% of expression of distalization. So we don't need to overcorrect a lot our distalization, but pay attention to that on our final position in the ClinCheck. And then after that, it's elastics. Start early. As I said, I go light every night, after school as well, if we need a few more hours, and start in the second appointment. I don't wait until mechanically I might need them, which is when the premolars and the anteriors are coming back. I want the patient to already be very comfortable with wearing elastics, so that if I did need to go a little, some more hours during the day, the patient is very comfortable putting them on and off already if they need to do that at school or at work. So really it's communication at the beginning, preparing a great ClinCheck plan, monitoring and always checking on that compliance is going to help prevent, my whole thing on finishing, and Dr. Isha and Dr. Arm will tell you, if you go to I'm really glad Dr. Huang is giving a finishing lecture, because if you attend one of mine, it's really not typical Invisalign finishing. It's not cutouts and elastics and cutting Viveras and these things. I do that occasionally, but my whole thing is prevention, and I try and prevent the problem. And then if I need to correct something, it's also using the digital system, which I think should be the most efficient, but with a different strategy. Never repeat the same thing that didn't work the first time. So yes, I will use an additional aligner series for finishing, but with a different strategy of movements. Otherwise, it's the definition of insanity, right? Doing the same thing, but expecting a different outcome. Another thing, showing the patients pictures of elastics with aligners is really great, because they know what they're in for. Placing, you may have seen on some of the elder patients, or placing elastics on the first premolar and not the canine, just trying to bring them back a little bit in the mouth, make them more aesthetics, maybe encouraging them more to wear elastics. I don't do that so much anymore. If someone's very, very particular and I'm distalizing a long way, perhaps, but if you put the elastics on the 4 to get a really good force system, you probably want elastics then on the 12-year-old molar, and sometimes in teens they're not erupted, or they've got short clinical crowns, or there's no room for an attachment and the hook, and they can also, it's the more flexible part of the aligner than where the 6-year-old molar is, so it can lift the the aligner off the dentition if it's on the 12-year-old molar rather than on the 6-year-old molar. But feel free to change the position of your hooks and cutouts if you need to. 4 to 7 works. You just have to have very good attachment retention of that aligner on or very close to the 12-year-old molar, perhaps the distal of the 6. Clean check preparations showing limited goals to full distalization. If I really want a patient to buy into this lengthy treatment plan, then is there an alternative? So I may, if it's possible, show them an easy way out if there's no functional issue with the class 2 if they're an older patient, and a limited correction versus a full distalization on clean check. And we have that beautiful clean check software to be able to do that. So back to those two things. One can be simply just a non-fit on a particular tooth. And this is a patient here. You can see the hook is on the first premolar here. We're distalizing. I know she's super compliant. Her sister was also in treatment, really compliant patients. So I can see the aligner is adapting very well around most of the teeth, but look at this tooth, what's going on? So when this happens, you stop and you breathe and you ask yourself, actually, does it matter right now? If this is the first series of aligners, for me, it really doesn't matter mechanically, but you want to know why it's happening, because at some stage you want to fix it and you don't want it to happen again. Again, for me, finishing will be a refinement. Most of my patients will have, my goal is one short finishing series, not more aligners than what we had in the first place, a short finishing series of new aligners that will finalise those torques, tips, maybe take out that final proclination if we maintain a really acute interincisal angle. So I want to know why it happened, but do we have to do something now? And if we, why would we want to do something now? Maybe it's an aesthetic concern. Maybe I think the patient's not going to be as compliant when she has to walk around like this. So in that case, then I'm going to restore that. And you probably all know the easiest way to bring down a tooth like this will be that button and elastic. So here is our patient with her class 2 malocclusion, and not a very deep bite. Needs a little bit of upper incisor and a tiny bit of lower incisor intrusion, a little bit of crowding, just mild crowding. But definitely class 2 molar. Here the vertical is, as I said, not as bad, a little bit of intrusion in each arch. What I would be considering here is the anterior limit. Right, start with the lower arch. What is my anterior limit? How far can we actually procline those teeth? Something that we don't often consider is distalizing the lower. Sometimes the lower arch is not symmetric, and in order to get the class 1 canine, and we want to have symmetry in the upper, is to make the lower symmetric. So sometimes it's a matter of distalizing one side in the lower 1 millimeter or so, and that's quite doable. Get the canine symmetric. So the anterior limit and the canines should be symmetric, and the anterior limit I like to tell to the technicians. For those of you, if I haven't made it clear, the anterior limit is, for this case, it's probably maybe the 3-1 would be an ideal anterior limit. So you tell the technician that, and they're not going to move that tooth further than that initial position of that 3-1. Want to make that arch symmetric, nice and level. It's not very deep arch. I'm not going to overcorrect that deep arch. So molars go back, the green zone, and then the I alternated here the canine and incisors. Now I bring the canine with the premolars. This takes more stages to do, and I don't think it's much advantage. I don't need to bring the canine by itself, but it's an option. Some of you may want to do that. And that's the beauty. Everyone's going to use Invisalign slightly differently, just like fixed appliances. So have a look what's happening here on the right-hand side. Molars are going back. Let's look at why this canine. What's happening? It's distalizing. Where is the push surface on the crown of the tooth? Perhaps as the aligner is distalizing, it's intruding a little bit as a rebound effect. But what else is that tooth doing? When we use superimposition, it's actually extruding. And you can see there's no attachment on that tooth. So probably, well, the extrusion's not going to express. There's no undercut there. And it's even possible I had some reciprocal intrusion. Remember, when teeth are moved, it's sort of the opposite to fixed appliances with aligners. With fixed appliances, we tend to extrude, get unwanted extrusion. We have to be careful with our dolicho patients, and we open our mandibular plane angle very easily. With fixed appliances, with Invisalign, we tend to intrude, even though we may not want to. So here, very, very simple solution. I could have also waited until the finishing series. And this is the button and elastic. I usually keep this on only for about a week. It will come down in a day or so, but then you want to hold it preferably a little bit longer than a week, but it's nice to get the button off, and then I'll get my little pressure point pliers. So the next aligner will come in and I'll put a little pressure point just in the contact points so that I don't get a lot of reciprocal intrusion from those periodontal ligament fibers. But you can see once the tooth is extruded enough, just simply with that rubber band, we make sure we trim the aligner away from the button. So, you know, this is a very quintessential aligner auxiliary, but these days we shouldn't need to do this a whole lot. We really want to rely on that precise digital programming and the outcome that reflects the final position that we created in the ClinCheck program. So just a bit of a final case here. She's actually an extraction case, but the message is quite important because as I said right at the beginning, one of the alternate treatment plans is extracting upper premolars. And we'll come back to Ava. This patient's quite interesting for lots of reasons. But in her case, first premolars were extracted instead of distalization. So we still have to retract, just like at the end of distalization, the canine has to correct and the anteriors retract. So those mechanics are very similar at the end of distalization to the end of extraction. And we presented exactly those different treatment plans, a distalization and an extraction. Distalization, this is why I call it the cake. It's almost like a wedding cake. The molars go back and the middle zone and then the incisors. Can you see the features on the ClinCheck here? We were talking about aligner features for controlling the incisors, and we spoke about power ridges, and I said I'm going to come back to bite ramps. Now, bite ramps are interesting. I don't want to talk all about vertical dimension. We'll have a few questions in a moment. But for me, usually they go on the canines because they can work straight away, and I can still have the luxury of palatal attachments if I need to. So Ava chose extraction because she didn't want to wear elastics. And this is monitoring, right? She came in and left-hand side's going beautifully. My canine is class 1. My molar has very little, if any, tipping. Right-hand side, not so much. What's going on the right-hand side? Right-hand side, I haven't corrected my canine like the left, and there's a lot more molar tipping. So something's happening here. And it's really interesting to go back and troubleshoot. My midlines are on, so that's great. She's happy, the anteriors are aligning. I'm not happy with this, particularly the canine. Why is not? I know we can distalize canines. I know we can do that. So the worst thing, what's the worst thing you can do here? Not so much because of the canine. I can start that again, but it takes a long time. The molar tip, right? What's going to happen if I have a block here and that molar, everything's just being squeezed together? The molar can get worse. That tip can get worse. So next time she came to see me, again, the left-hand side, great. Right-hand side, that same block on the canine and even more intrusion on that molar. So something is not tracking here on that left-hand side. So what do? We go back and see our programming and we ask ourselves why. Let's have a look. Now, even though this is extractions, not our topic, we're talking about distalizing canines and what can go wrong. This canine, we spoke about the interference from the lower canine, the occlusion. Let's have a look under here, what we have. What is that feature there? That's a bite ramp. Right? And that aligner is pushing back that canine. And every time the patient bites, and they still do with their aligner on, it's preventing that expression. So in fact, because it's an extraction case, it's also the canine's not going back, so the molar's tipping forward. It's losing the anchorage. On that left-hand side, it wasn't an issue because the bite ramp was just out of the way. So this just teaches me really to look at not just the AP in distalization, not just the vertical when we're talking about deep bite. Digital programming is 4 dimensions, right? It's vertical, transverse, AP, and time. So, and what we want to do, we've got to look in 3D. Tip it up, have a look and see, is there any interference? Usually I'd be checking for the canine, but keep the features on if you're going to use, because often I'll do this, I will check for interference, but I have the features turned off and I would have missed that bite ramp. And that's why the left-hand side is working well, because it's actually pushing it into place, and why my left-hand side molar is not tipping a whole lot, even though similar crown length, similar attachment. So we did a correction and whenever we have a tip tooth and we correct them, we distalize. So remember, crown tip expresses very well. So we distalize that molar, and then if we need to mesialize it, we do it with full control. And we make sure we don't have any interference on that canine. So just a message there about interference. If we summarize now, what our mechanics looks like, we have, whenever we're increasing the arch length, we have very little negative effect. When we're decreasing, that's when we can interfere anteriorly and also posteriorly with the molars can have a very similar reaction to that case that we just saw, but the mesial would just intrude. So these are the things that we can control apart from our patient: final position, IPR, attachments and features, and staging. Have a consideration of, about those things, whether you can have 6 stages, you can have 8, you can have 4, it doesn't matter, but as long as you remember to systematically check these things, and these notes here are just particularly relevant to our class 2 cases, things that I might consider. So I hope that that summary slide helps you a little bit. again, I'm happy for you if you want to take a shot at that. If you haven't already, no problem. So any key messages here before we go to some questions? Diagnose the cause of the class 2 malocclusion, because that's going to guide you to the treatment plan. Is it skeletal? If it is a skeletal component, for me, I always suggest a visit to a surgeon, even if I think they're not going to have surgery, because to change their mind halfway through treatment is not something we want. In terms of selecting the mechanical option, do we want to bring the mandible forward without a more functional effect with the mandibular advancement feature? Do we want to rely on distalization with elastics and aligners, which in certain actively growing patients will also give us, I believe, a certain functional effect if we hit that right time in growth. Prepare a ClinCheck Pro software plan reflecting the treatment goals. Is it going to be a limited goal? And in which case, for me, I'm not going to move that posterior occlusion, or I'm going to build in very minor movements if I need to, just to help get that nice, arch form. Again, limited goal for me is much harder final occlusion to set up because there are compromises, and it's where you're going to compromise. But I don't want to create a second incorrect occlusion. I don't want to move everything but still not correct the class 2, because if the patient's not comfortable with that final occlusion, then our treatment has been really for nothing or making the patient worse off. So be careful with the limited goals. Right click and lock those posterior teeth. Start from that position, that's great. Evaluate ClinCheck systematically. There's a lot to look at. Don't be afraid to consider all 3 dimensions and run the teeth, not just the initial and final, but run them through, because the staging is really, as we go through this series, you'll see it does explain a lot of the effects that we see in our final outcomes. Begin class 2 elastics early in treatment. If we're relying on, distalization or an elastic jump, we need that inter-arch mechanics. So the patient needs to be compliant. They need to know ahead of time. It shouldn't be a shock. It's like putting money in the bank. If we start early, we may be able to stop early, or we may not have to, make a big rush and in the last 4 aligners go, 24 hours a day wearing elastics trying to correct another 2 millimeters of class 2. We don't want to create a dual bite. Monitor and inform the patients throughout treatment. So, think about your frequency of visits. The patients, I think, do the compliance, every patient, the compliance is different, but I do think that face-to-face is something that encourages the patients, if they're becoming a little bit slack, then to start, wearing those elastics every night again and keeping up the hours of that aligner wear. Or you can go to something like virtual care, which you have access on your IDS. It doesn't cost any more money to have that additional monitoring for our patients, which is great. And then retention, for me, it's Vivera. It's a no-brainer. It's 3 retainers, so they've got spares. They're so well made. They're used to that appliance already. It's trimmed the same way as their aligner, so it's very comfortable for them. And I have that scan in my beautiful iTero if they need to order new aligners in the future, which they will, new retainers, because they're wearing retention for life, because everything moves, right? And it's never going to stop, which is great, because that means we're alive. So with that, thank you very much. And I will ask if there are any questions, and I believe there are. Thank you.
Thank you, Dr. Vicki. Very nice and interesting lectures. I think the doctor will be very confident after your lecture. And yes, we have a few questions in the Q&A box. Then let's go through each of them. The first question is, thank you, Dr. Vlaskalic. For your class 2 cases, are you just using sequential distalization now, or do you use carrier and you move into aligners?
Thanks for the question. I don't use carrier. I don't use carrier because the people who use carriers, the doctors who use carrier, are doing it usually because they want a faster distalization first, and then they'll move into the alignment with the aligners. I find that carrier, last time I looked at them, there are some effects, the lateral effect that can distalize and lateralize and also intrude. And to undo those effects of the carrier, it almost takes away the benefit and that additional, that delay in starting treatment, the delay in aligning the anterior teeth. I just prefer to do it all with aligners. So I hope that answers your question. I think it's a totally valid way of doing it. And if you're very comfortable combining those mechanics, why not? But when I can distalize and align the anterior teeth and control my lateral and extrusion or extrusion, as I said, distalization, we don't see any kind of crazy associated movements. It's quite easy to control. So I just do it with the one appliance system.
Thank you. The next question is that since you are distalizing the maxillary molars, do you prefer to start the teen case before the upper sevens erupt?
That's a really good question. And, a lot of doctors are really afraid because of the anatomy. What's going on with the third molars if the 12-year molars erupted? What are we doing when we're distalizing? In the case of third molars, which tends to be more common there, the 12-year molars will be erupted and we're distalizing. If they're going to be extracted and they're going to be impacted, then I will, and they're low enough, I'll send them off, obviously, before we start the distalization treatment plan. It may help to express more distalization, even though it's a very highly expressed movement anyway. The risk, I guess, is it slowing down, having a tooth behind what we're distalizing? Is it slowing down our distalization, or are we going to cause damage? And I am not aware of any cases of, root damage. And maybe we will change our minds now that, we can see cone beam on the ClinCheck. Perhaps some of us are going to take more cone beam, even though we still have to be careful with the radiation.